Hey guys, welcome back. We are on our last few sessions for the 24-hour marathon. This one, we're going to have Diego Zanolli from Chile moderate. He's going to be talking about MIS, minimally invasive surgery for Hallux Valgus deformities. And this one's brought to you and sponsored by MedCom Carolinas. Diego, it's all yours.
Hi, Selene. Thank you for inviting us, and thank you for considering us here in Chile. It's an honor to participate. And without furthermore delays, I'm going to introduce you my panel. And I would like to tell you our experience with minimally invasive. This whole adventure has been very nice for all of us. Our panel is composed by Dr. Stephane Elgueta. He works at the Diprega Hospital of Santiago and Clínica Bicentenario. We are all from Santiago, Chile. Our next panel is my boss. He works in Clínica Alemana of Santiago, Andrés Keller, who has made a lot of good experience with minimally invasive surgery. Leonardo Lagos, who was the former president of the Chilean Foot and Ankle Society. He works at Mutual de Seguridad of Santiago and Clínica Santa Maria, a very big hospital here in Santiago. And Dr. Pablo Mococain, who works also in the Parekh Hospital of Santiago, and is a colleague of mine in Clínica Alemana in Santiago, Chile. And myself, I work at the Military Hospital of Santiago and in Clínica Alemana, and I'm the current president of the Chilean Foot and Ankle Society here in Chile. And I can't start without saying thanks, Helene, for all the hard work. We have really enjoyed all your presentations, and I will share you a couple of pictures while you and your family visit us here in Chile. We're looking forward to have you here again. And without anything else to say, just to say, why go miss? This lady, she has a moderate bunion. You can see it here in the AP view of the foot. I have a lot of experience with this open surgery. I did a scarf, a rotational scarf. I stabilized it with 2 bones, the scarf, and also do an Mpj Osteotomy. And actually, it worked pretty well for her and get a very nice correction. Not only that, but she also, at 4 months, she was able to wear high heels. So she had a very good range of motion, pretty aesthetical result as well. She cannot see the scar in the medial side of her feet, so she's very happy with it. So why change? And why change, Leonardo? What do you think about going minimally invasively when open surgery works pretty well? Leonardo?
You are alone.
Sorry for that. Thanks for the invitation. I say that my answer to your question, Diego, is probably more a philosophical answer than an academic one. We're going to discuss all the academic issues, what about the literature, what is published. But of course, we have to move on. And the idea or the concept to have a minimally invasive surgery with less soft tissue damage is not only attractive, it makes sense. And if you see the history, not only of the orthopedic surgery, about all kinds of surgery, is going about the history, moving on to minimize the issue about portals with the laparoscopic, with the digestive surgery. The rotator cuff is a good example from the open ones to the shoulder guys now go to arthroscopic or endoscopic. So probably what we have to do, and with the new techniques, with the development of the surgeries, we're gonna have to decide in which cases is a better option. We are moving on that, but I think it's what is coming on for at least the Hallux Valgus and forefoot surgery.
Okay, and Andres, do you think with all the power and all the data published for open surgery, for scarf osteotomy, for lapidus, for even chevrons, there's a lot of good results published out there. So, do you think the evidence published already supports going minimally invasive surgery?
Yeah, I think yes. There are some systematic review that shows that the minimal invasive surgery in Hallux Valgus give good results. And that is a key point if you decide to change from the open surgery to the minimal invasive surgery. The literature agree with this indication, and in my opinion and in my experience, the open surgery and the minimal invasive surgery have the same objective. The main objectives to do a hallux valgus correction is the same. It's another way to do that, nothing else. Yeah, if you have a lot of experience with the scarf osteotomy, you can continue to do it. But if you think that is a space to improve your results, I think it's possible to integrate the minimal invasive surgery as part of your tools to treat hallux valgus.
Okay, I agree. I guess we are young enough to, start learning things new to help our patients better. So, Pablo, can you actually show us how to do that?
Okay, Diego. So let me share my screen. And let me know if it's okay.
There you go. That's perfect.
You can see that?
Yep.
Yes.
Okay. Here we go. So I will present you an MIS case. This is a typical case, no secrets about it. So this is a 35-year-old woman with a painful bunion. She has no metatarsalgia and an MIA angle of 15 degrees. So this is a very typical case. I would like to know everyone decision-making. How do you approach to this pathology? So how about you, Diego? Which is your decision-making when you are in front of an hallux valgus?
Well, definitely I'll look for obviously the complaints of the patient, but assuming this is no tricks and she's only hurting in the side of the bunion pain and nothing else, I will go to the AP X-ray and I'll see the MIA angle and also what we have published in our group, which is called the angle to correct, and try to get that metatarsal head over the sesamoids. And I think I don't want to go further with that yet, but I think this will be between a moderate and a mild case. I'll try maybe to do a chevron. And since I have some experience also with medial invasive surgery, I'll try to do an Mpj osteotomy. I'll go chevron with her.
Okay. And how about you, Leo? What is your decision making when treating hallux valgus? How do you decide which technique is for which patient, for each patient?
Well, I have a lot of experience with the open surgery, just beginning with my MIS experience. So I feel comfortable with open ones, but we're in MIS. This is what about. So in any mild case, I prefer to do a chevron. I think it's not that far or that difference about the scar, the surgical aggression, if you compare it with a MIS. But if you're going, for example, for a moderate case, this case you could classify as a moderate, 15 degrees IMA angle. Probably you can decide a scarf. And I think, and there are some works published that with a scarf you have more stiffness compared with MIS techniques like the Mica one. So in this case, I think I can go for a Mica.
Okay, so both of you mentioned the IMA angle in your decision making. What do you think about that, Stephane? Because some patients has had like a little bit of adductors from metatarsal abductors, nothing pathological, of course, but just a little bit. So you can get a smaller IMA angle, and you can make the wrong choice because of that. And you can choose like a chevron in this case, which is a technique that in my hands doesn't have that much power to correct the deformity, and be like tricked by that smaller IMA angle. What do you think about that? Do you have something else to make the decision?
I agree. Maybe the metatarsus adductus can lesser the IMA angle, but here I think a chevron will be a little, maybe you have to push a little the limits to a chevron, and maybe it's gonna be undercorrected with a chevron. So here I prefer to do a Mica surgery, which is more powerful, and I have more room to play with it.
Okay, so let's move on a little bit. So Andres, when I was during my training, you were one of my teachers, and you and others one told me that that MIS surgery was for older patients, that for local bad tissues or comorbidities or something like that. So do you think that the indication has changed for you?
Yeah, of course, have changed. At the beginning, we started doing percutaneous in old people, but we have had not good result in some cases. And with more experience, when you do every week, some cases doing Mica or Mpj Osteotomy, you feel more confidence to do surgery, minimal invasive surgery in young people. For me, in my hands, I think the minimal invasive surgery could be for young people and for old people. And maybe the risk today for me is the osteoporotic bones. In those cases, I do in those cases, but it's not comfortable to me to do that percutaneous because the risk of broken the construct. Yeah, that is a big issue in when you have an osteoporotic patient. But on the other hand, for young people, it's an excellent option today in my hands.
Okay, I'm totally agree with that. I would say that in the beginning of my learning curve, I made that mistake, and I performed this surgery in old people with poor bone quality, and I make some mistakes. But now that as you get more comfortable with the burr, you can extend your indication and also do it in those population. But I think that my ideal patient is young patients. It works really, really well in those. So Stephane, what do you think? Where's the limit for MIS surgery? Do you think that it's for everybody, for every bunion, or do you have some restraints regarding the indication?
Well, it depends on the deformity and, of course, of the patient and his complaints. And if you have to consider all that things to choose the right MIS technique, or maybe to choose to do an open technique. Maybe a little bunion, like some of you comment before, you can choose to do an open chevron with an misaching, for example, and with an open chevron, you did a minimal soft tissue damage. So there's maybe not so a great advantage of going miss. That's one thing, and maybe a very severe deformity. Mica technique, a classical Mica technique, will not be sufficient to achieve a good correction. So you have to do another technique. And well, I go discuss this in my presentation later.
Okay, that's great. So we all agree that maybe a chevron is too little for this bunion. And sorry, Andres, do you want to say something?
Can I say something?
Yeah, of course.
Oh, of course.
So in this case, in my hands, I think the chevron osteotomy, the open chevron osteotomy, is not enough to correct the whole problem. Remember that the problem is to restore the normal anatomy. And I think to do that, doing a chevron, an open chevron, you need to move more than 50% of the metatarsal head. And then with this movement, you start at the risk of bad union and start with the head invarious. So I think it's not a good idea to do this surgery with a chevron technique, with an open chevron techniques.
Yeah,
With the
I'm totally agree, and we are in the MIS discussion. So yeah, here is an MIS solution for this case.
Well,
So,
show us, Pablo, what you did.
So let's move on. This is what I did in this case. So I choose a third generation Bosch osteotomy. So it's a straight cut. I choose it because it allows me to correct in multiple planes the deformity. It's an extra-articular osteotomy with an unstable fixation. So where this came from, it's all from what David Redfern and Joel Bernard had shown us in the previous 10 years. They are great at doing the Mica. They're the creators of the minimal invasive chevron. This is a well-known osteotomy with an stable fixation. It's an extra-articular, which is very important, and we will discuss that later. And most important of all, it has shown to be a reproducible technique. So in the last few years, we have seen a lot of publications around the world showing excellent results and very predictable with this technique. So why I like it? Because I think it's very versatile. You can, depending on the position of the burr, you can shorten the metatarsal if you need to. You can lengthen the metatarsal if you need to. And you can even elevate or descend the metatarsal head if you need to. And so you can move the head around, and this is very helpful in some cases. This is how we do it. This is a Mica osteotomy, so a chevron osteotomy. We use 3 portals, and this is what we call MIVA, so a Bosch osteotomy. We use the same 3 portals. I begin by placing the K-wires. I try to go as proximal as I can and get the largest screw, the longest screw that I can put in. So once I have the K-wires placed, now I have to make my osteotomy. I decide the direction of the burr. In most of the cases, I don't want to short the metatarsal, so I just compensate by the resection of the burr by leaning the point of the burr distal like 10 or 15 degrees, and that's enough to, when you displace the metatarsal, to get compensation of that shortening. Then you displace the metatarsal head, and if you need some more correction or reduction of the sesamoids, you can use some tricks to reduce that under the metatarsal head. And once you're done, you can place your screw. This is what it looks like. And after the screws are placed, you just need to shape the medial bone eminence with a conical burr. And this is what you get. You get a very consistent result. You can displace the metatarsal head an 80, 90, or even 100% with any trowel. This is a very strong construct that allows patient to weight bear immediately. And we are really very happy with it. This is the clinical result at 6 weeks with a foot with a little bit of edema, and the scar is barely noticeable. This is one of the things that I really like about MIS surgery. As is an extracapsular osteotomy, you don't mess with intraarticular tissues. It is very rare to get joint adhesions. You can allow early range of motion, and as you see in the image, a patient that has, I think, 2 weeks of post-op and has nearly full range of motion. So that's really, really great. But for me, the main advantage of MIS surgery, then that's the question that Diego asked before, is pain management. I really think that this is the main advantage of going MIS. It is very clear that patients need more painkillers versus open surgery, and they report less pain in the first six weeks. So why go MIS? Because I think that we can do better for our patients.
Can I?
Yeah. You want to say something, Leo?
No, but after your summary, I want to ask you a question.
Yeah, of course. So just to summarize, my Mica or my MIVA osteotomies, I indicate those in moderate to severe deformities. I totally agree with what Stephane stated before. I think that small deformities do great with a chevron and an MIS aching. Mica or Miva can achieve, or they have a great correction power, so you can take care easily of severe deformities. And in concrete, Miva allows for multi-panel correction. They are very versatile technique. They can be very helpful in revisions or in cases with metatarsalgia or in index minus. They can be really helpful. I think there are clear benefits versus open surgery, principally pain management. And you have to take, also you have to take home the lesson that there is a learning curve that is really important. You have to train a lot, you have to read a lot, and I hope that you can talk a lot with people that have done this before, because if you start by your own, you will get in trouble. So practice.
Absolutely, as every technique. Well,
Yeah.
Leonardo, you wanted to ask something to Pablo?
Yeah, one question.
Yeah, of
I
course.
totally agree with the previous you all guys said about actually there is not a contraindication or a better indication with the osteoporotic bone, but with the few literature we have, it's not few, but a lot of level 4 studies, some level 3 studies, but a recent study about the biomechanical one talk about the failure can be in a Mica technique in the osteotomy side or in the point of entry of the screws. Did you have, Pablo, in osteoporotic patients, older patients, some failure, some problem with that?
Yeah, I have one failure.
The loss of chase?
Yeah, I have one failure, and it wasn't in an osteoporotic patient, and it was my second case actually, and that was when we were doing things a little bit different. I was using 2.0 K wires to start, and probably do too many entry points, and it was like a Swiss cheese. So I got the failure because of that. I don't do that anymore. And I use 1.1 K wires to put my screws in. So, and I just one entry point. So I don't have any more loosening of the screws and failure.
Okay.
Probably it's more a learning curve problem.
Pablo.
Yeah, absolutely.
So there was a question to piggyback on that question. When you perform your Mica, have you changed from the original technique, or are you doing any kind of variations? And specifically, they're asking, are you doing a tenotomy of the hallux adductor? Are you fixing the failings if you're doing an Aiken with a screw or not?
I love, Selene, that you asked the question, because I think Andres, with his next presentation, he can explain us if there is any variation between the Mica or the Miva, right, Andres?
Yes, of course. But I would like to say something about the techniques. If you decide to do or to use a technique in a patient, it's very important, not only the pain post-operative. As Pablo, I agree with Pablo that this is a part of the treatment to have less pain, but it's not the only thing you need to in your making decision. I think it's most important to choose a technique that give at the midterm or the long term good result. And that is the key point, in my opinion. And today, the minimal invasive surgery gives at midterm good results. So I think it's a good option. And in my hands, I have had good results in my patients.
So actually, Andres, I'm glad you brought that up, because somebody asked that question of what is the success rate of MIS versus open?
Well, great question. I don't have published our results, but Dr. Redfern, for example, he has a lot of experience doing these techniques, have more than 91% of successful. And with open techniques, it depends. Scarf, 85%, 88%, and it quite similar results today.
Okay. And some other question, what's the ideal percent translation of the head? 75, 80%, 100%? And how do you determine that ideal translation amount?
So I think that there is no ideal percentage of the translation. So you have to translate or shift the head enough to get the sesamoid redux under the metatarsal head. So if you translate 50%, probably in this case, that wouldn't be enough. That is why I don't make a chevron osteotomy in this case. So Mica is designed to perform great displacements. If you don't need to displace more than 50%, go with a chevron and go with an open surgery. I don't know why to choose MIS in a little deformity, but there is absolutely no trouble and no problem to shift the head like I show you, like 100%.
And Pablo,
you can repair that safely.
And Pablo, which one shortens the first metatarsal more? That's another question.
Yeah, we are actually doing that study right now, comparing the scarf, the open chevron, the promo, and the lapidus versus the Mica. And why I can tell you our preliminary results with the Mica. You can, as I show you, you can compensate the shortening of the bear with the direction of the cut. So it's very rare that you produce that much shortening. So 1 millimeter, 2 millimeters is not that much.
No.
But with the other technique, with a lapidus or with an open chevron, it's more difficult to get that right. So that's not really a problem.
All right, and then one last question, and then I think I'm caught up on questions. A recent paper by Gordon in the British Journal stated 20% complication rate with MIS. So this person's asking, where's the evidence that MIS patients require less analgesia?
Yeah, so we have several complications in our learning curve, probably in our first 20 patients. I will tell you that we had a lot of burning portals because of the heat of the bear. We don't have the irrigation system here in Chile, at least not at the beginning of our learning curve. We have a little, 2 patients with failure of the synthesis, whether that was I was telling you before, but probably 90% of all our complications were due to our inexperience in the first 20 patients. That probably you will have all that complication with open techniques also. So this technique requires a proper training, proper study, but I'm not saying it's better. I'm saying it's versatile and just another tool in your toolbox. So open surgery still have an indication in my experience, in my practice.
Can I add something, please?
Yeah.
Also, this 20% of failure with missed procedures, they are mixing missed procedures. They are a lot of missed procedures, and they are not all the same. You are Mica surgery, you are Parekh surgery, you have first generation missed surgery without fixation, and you can't put all of these techniques in the same bag.
Yeah, I agree.
Absolutely.
Yes.
Absolutely.
Right.
Well, Andres, can we respond to Selene's first question regarding the modifications of the current Mica that everyone has been told?
Yes, I would like to share my screen to show a case. This is another case of missed surgery. Can you see it?
Yes, perfect.
Yes. Perfect.
Okay, this is a very common case. It's a female, 44 years old, of course, with this bunion, as you can see, and cannot wear high heels and cannot play sport. And she came in my office without metatarsalgia or any other problem, just bunion, just pain to wear shoes. So the X-rays, as you can see here, the AP view and the lateral view shows an EMA of 13 degrees and the Hallux Valgus angle was 23 degrees. In the lateral view, maybe the hindfoot is in a valgus, not so much, but it's in valgus. and the rest of the X-ray shows good. So I would like to know from the panelists, what are you going to do in this case? What think you about this case? Are you going to do the same percutaneous openly? What kind of techniques will you do?
Well, if I can respond first, and as I told in the first case, when you have a mild deformity, for me the IMA is probably the angle where I can classify if mild, moderate, or severe. And in this case, I would do a chevron. I do it with a minimally, it's not minimally invasive, it's just a little open with just a very short soft tissue damage. So in my hands, I do a chevron.
The chevron. And Stephane?
For me, it's...
Are you going to do the same? Or you prefer to do as percutaneous?
No, for me, it's a perfect patient for a missed surgery, a Mica particularly. I think she had a little index minus, so I will consider it when doing the cut with the burr, not to shorten anymore. I know she has no metatarsalgia, and we want to remain like this, so I take this in mind.
Okay, and Pablo?
I'm totally with Stephane.
Okay, so now I have this sun view. With this sun view,
Oh boy.
The problem. This is the problem. This is what I want to talk. I don't know why, but this is what. What about this round shape of the head? Does it matter or not? Is it important? Have a risk for something or not? Or is the same? Are you going to do the same viewing this image or not?
I have to be honest, and I will maintain my decision. I know this. We are showing a rotation problem. We have some studies published that they have some literature that you have less results or worsen results in patients you don't go for the rotation problem. But until now, probably the main problem is we don't have an accurate tool to really measure preoperatively or in the intraop how much you have to correct, how much rotation. If you have some rotation, that will influence in the results, not. So that is the problem for me. I have to. I know the rotation is a problem, but I don't know how to handle it. That's very honest, my answer.
Perfect. And Pablo?
Yeah.
What do you think about this shape?
So you're showing me a round shaped head, and you're asking me for the rotation. So I do change my approach in these cases. I think that mild rotations can correct itself when you align the metatarsal, and that's no problem. I'm also agree what Leo said before, that we don't know how to properly measure this problem. But I think this is a moderate case of a rotational deformity, and I will make a straight cut. I will make a third generation Bosch osteotomy. And if with my displacement, or when I shift the head laterally, I can reduce the sesamoids. Probably I will do the joystick maneuver that I showed you before to make that sesamoids be placed under the metatarsal head and have a perfect reduction. So I will change my approach in this case.
And how do you say that there is no a good instrument to measure the pronation of the metatarsal? What about the X-rays, the AP X-ray? What about the weight-bearing CT?
Yeah,
Can
weight
work.
bearing CT it's a great it's a great way to measure pronation. I totally agree with that, but we don't have weight bearing CT in the OR. So once you're in the OR, how you are going to deal with this pronation?
Okay.
I can ask you back.
No,
How
I
do
know.
you
I don't
deal?
have the answer. I ask you first.
Yeah, so it's
Diego, you as
just
moderator have an answer?
yeah, it's
Well,
just an estimation.
of course, both guys I speak with the truth. I mean, there's no way inside the OR you can actually measure that. What you may do, but I think you are going to increase the bill of the patient if you're going to ask for every bunion for a weight bearing CT. But if you want to pay for investigation or research purposes, I think that's okay. But having said that, you can actually, with the weight bearing CT, may try or may have an idea how much you have to I mean, correct. But in any case, that doesn't matter, because if you when you do your cut, what you want to see is that those sesamoids are under the metatarsal head. So maybe, like Pablo said, with a straight cut, maybe you're gonna rotate that head until you get those beautiful sesamoids under the metatarsal head. It doesn't matter. Probably you may think how much you have to shift it with the weight bearing CT, but anyways, you are gonna rotate it as much as you need. That's what I think.
Okay, I agree with you. Maybe Cesar De Neto says different things. But today the weight bearing CT shows very well hyperpronations, but less pronations. And what is normal pronation? Today, nothing could say the 14 degrees, 13 degrees, 10 degrees is a normal situation. So, but I would like to share with you what I have done. So,
Hey, Andres, quick question. How do you ever take into consideration the DMAA? And if so, how do you correct that?
I don't consider the MAA angle, okay? But you can see that is the final result, that the DMAA is in the right position. So I think if you rotate the head of the metatarsal, the angle will be correct. Here is the result. What have I done? In this case, is not a formal Mica chevron, so I did a MIVA chevron, a Mpj Osteotomy, a transverse cut, yeah, and the lateral view you see is well aligned. And here in these pictures, this is the pre-op image and the post-op image. And with a simple key wire, you can make an internal rotation to put the sesamoid below the head of the metatarsal. And then maybe this maneuver can correct the DMAE. So that is what I have done. Of course, when you decide that the head is in the right position, you transfix the head of the metatarsal with key wires and then put the two screws. Here is the final results. And 2 months later, you can see small incisions. This is a very small incision. This is a portal where through that portal, you can cut the metatarsal, and the other portal, you can make the aching osteotomy. Okay, so with this MIVA surgery, you can restore the normal anatomy of the first metatarsal. So my case was a multiplanar deformity, and the MIVA can address this type of deformity. So the MIVA do the same as open rotational technique, but is less aggressive. So this point is the key advantage for this technique. But up to now, there is no consensus in the literature what is the normal pronation, when it's necessary to correct, and how to measure, as the panelists talked. And finally, remember that not all the bunion need a triplanar correction. in some cases, maybe just doing a Mica surgery, I don't know why, the pronation will correct it. I don't know why. Maybe because it is an extra capsular osteotomy. That is my case, Diego.
Well, thank you, Andres, for showing us and show us the difference between a Mica and a Miva. And I would love Stephane to respond. Another question Selene made is about, do you do any soft tissue procedure while you do your correction? Does lateral release ring any bells, Stephane?
Well, I don't really. I will explain you why. But I want also to answer the another question Selene made about the DMMA. I think with a Mica surgery, you can also correct the DMMA, and you have to shift the head of the metatarsal laterally, and to shift also in a little varus to correct the DMMA before putting the screws in, and so you can correct the DMAA also. And I want to show you a case for answer your question, Diego, about the lateral release.
Perfect. Meanwhile, you are putting up your present. There you go.
Perfect. Well, it's a case of a 61-year-old woman, a very active woman, who had a severe deformity, how you see in the images. She has an Hallux Valgus, very symptomatic. She have pain over the bunion, a crossover second toe, of course, with a pain over this toe, and a metatarsalgia of the second and third metatarsal heads. So she had problem with the footwear, and it was a painful foot. Here are the X-rays. You can see a severe deformity with an EMA of 21 degrees and a Hallux Valgus angle of 40 degrees. And with such a big deformity, what do you think? There is a space for missed surgery, or do we have to go open?
Can you show us again the picture, Stephane?
Of course.
Honestly, do you mind if I go first? For me, that's lapidus. I mean, in my hands, that's lapidus. I mean, it's too big to correct with a MIS surgery. I think may have to translate 100%, and I don't know if I can do that with a Miva or a Mica Osteotomy. I'll go lapidus.
And Pablo, what do you think about it?
I agree with you, Diego. It's a severe case. So there is reported some lapidus miss-techniques, but in my hands, I do a lot of lapidus. I think it's a powerful tool and a great tool. And in this case, I would do open lapidus with a plantar plate. And for what? With a plantar plate to allow early weight bearing, because I'm thinking to assess the metatarsalgia 2 and 3 with the MMAO, a miss technique. I think that's an improvement over open techniques for metatarsalgia like the whale osteotomies. And for the crossover, probably do a miss technique over the proximal phalanx. And probably, I think this can be discussed, but release of the dorsal capsule of the second toe and probably of the extensors. But I will do open lapidus and miss metatarsalgia once.
So, Stephane?
Great. Yes.
Yeah. So I think this is where the Mica or the Miva can't help us, because you have the intermetatarsal space is really too big. It's more than the metatarsal head. So if you imagine that you can shift the head laterally, you won't be able to correct the whole deformity. And you have to take into account that every time that you shift the head laterally, your proximal IMA, or the diaphysis of the metatarsal, will also move a little bit medial. So I think the Mica will not be enough in this case. And I will choose a lapidus. In this case, you can do it with an MIS technique. And I think that you can do this whole case with an MIS, do the DMMOs for the metatarsalgia, and also address the second toe.
Perfect.
but fusion, yeah.
And do you do early weight bearing with a missed lapidus?
If
We discussed before this, so
yeah, I know.
For the audience.
Yeah, so when we had done this surgery, all these cases had we also had done the DMMO. So that's this is a great question, because you need to put weight bearing to weight bear your DMMOs. But I would like to protect my MIS lapidus because I only have screws on it. But we have done well so far, weight bearing our patients immediately. So I feel safe.
Okay.
Okay, Stephane, you can show us what you did.
And how about Mpj Fusion? Someone of you would think about that?
What do you think, Andres, about that?
Openly or miss, maybe?
Would you do an
Andres,
MTP fusion, Andres?
Sorry?
Would you do an MTP fusion in this case, Andres?
No, I think the Mtp Fusion, I think the best indication is with a Hallux Valgus more than 50 degrees. And I think the problem here is in the tarsometatarsal. That is the instability. So I agree with Leonardo and with Pablo. In my hands, I will do a hybrid surgery. So open lapidus as traditional way and miss surgery for forefoot. But of course, the Mica, MIVA, or whatever different third generation of surgery, of missed surgery, is not enough to correct this big deformity.
Good.
Okay, Stephane, show us what you did.
So we are talking about miss. So there are a lot of techniques described for this kind of deformities, and how you say Mica, it's not enough maybe. So you can do lapidus. And how about lateral release? Maybe like with a lateral release, we can add some power to our correction. What do you think?
I don't perform lateral releases. When you perform a Mica, and it's an extra-articular osteotomy, you don't need to perform a lateral release to shift the head. And in a lapidus case, I think the same. As you're going proximal, you don't have any need of releasing the abductor tendon of the suspensory ligament or whatever. So I rarely perform it, and I think that it's not necessary. At least when I'm planning the case, I maybe do it if I'm a little short of correction, but not initially, at least.
I agree.
I agree. A little evidence-based about lateral release. This meta-analysis show a slight improvement in Hallux Valgus angle only when the suspensory ligament was raised, but no really an effect on the EMA. So I didn't use it usually. And about the sesamoid positions, this work from Wu shows no difference in sesamoid position with or without lateral release. So I don't think it's necessary. Here you can see
a bunch of questions. Are you guys open to taking some questions?
Yes, sure.
So the first one is, do you change the site of your osteotomy depending on how big the deformity is?
Me personally, no, I don't. I choose the technique in function of how big deformity is. Here you will see I don't did a Mica surgery. I did a lapidus one. I will show you after. But when I did a Mica, I did always at the same point in the neck of the first sesamoid, so first metatarsal. So sorry.
All right. And then, have any of you guys done Bosch Mica osteotomies in diabetics? And if so, did they heal?
Yeah.
Yes.
Yeah.
Okay.
No problem.
No
It
problem.
will be better. It will be better. Of course, will be better. Why? Because
I have also done
better.
I have done some proximal osteotomies in very rheumatic patients with ulcers in the bunion, and actually after you do that and you correct the bunion deformity, actually they heal. So yeah, we do them.
So The next question then is, somebody is commenting that they see the screws are bicortical on the proximal metatarsal, but don't go through the cortex on the head. The
Yeah.
original technique talks about tricortical screws, so it doesn't matter.
Not for us, really. We try to do it at the beginning of a learning curve, but I think it doesn't make any sense. It's strong enough if you have two big screws. There are also very long screws, more than 50, 55 millimeters, that have a bicortical purchase and also get purchased in the head. Dr. Cerato showed us in the AOFS meeting the best portion of the head to get the more dense bone. So I feel very comfortable with it. I don't think there's any need to go tricortical and purchase the cortical of the head, risking you to have an intraarticular screw now. So I think it's enough with this construct. And we also haven't had any rotatory problem because we used two screws. So I don't see the need of going tricortical.
And do you guys have a cutoff on maximum intermetatarsal angle to do MIS, to do Mica?
No,
For me, oh, sorry. Go,
Go, Pablo. Go on, go
Stephane,
on.
please. Stephane,
Yeah.
please.
Like Pablo says previously, the intermetatarsal angle not always shows the magnitude of the deformity, because you can have a metatarsal adductus and there the intermetatarsal angle will be false. Yeah, less than real. Okay, so it's more about the distance between the first and second metatarsal. If you have more than one head or 1.2 times the head, the width of the head between the first and the second metatarsal, then you won't be able to correct the deformity with a Mica technique. So
Yeah.
we prefer to choose another one, a more proximal. Yeah.
And also have to remember what Pablo Mococain said before, that the proximal MIA angle changes after you do your osteotomy. So sometimes you have to correct more than what you actually see before doing the cut.
Yeah, absolutely.
Great.
Okay, Stephane, show us what you did, unless Selene has more questions for us.
No, I don't have anything right now, and we got 5 minutes, so.
About the case, I did, how I told you, lapidus missed surgery. At the right images, you can see the joint preparation with the burr. And here is the picture of the foot with the portals used to do the surgery. And before and post-op pictures, here you have a 2 weeks post-op, and the patient is very well. She's now 4 months. She's already fused, and she's ready for the underwent surgery of another foot, the left foot. Yeah.
Oh, great case, Stephane. But we have shown a lot of different cases using screws, but I'm wondering if we can do this without screws. So Leonardo, can you show us, I know we are almost on time, but can you show us real quick if we can do this without any screws?
Okay, and because the time, I'm going to show this quick, and you can debate about this is an option actually or not. 65 years old, rheumatoid arthritis, about 20 years of treatment or even more, Araba plucking all the steroids, but she only has a painful bilateral bunion, yeah, with a preserved metatarsophalangeal range of motion and no metatarsalgia. These are clinically no tricks, pain in her bunions, angles. This is a case, and thanks to Sergio Fernandez. And the question, very quick, guys, please. That's the question. Fuse or preserve, open or miss, which technique, bilateral or just one at a time? You, Diego.
I think after all I have learned today, I'll go miss. And why no bilateral? Maybe if I'm afraid of the bone quality is not that good, I may be more conservative regarding weight bearing. But I'll go miss. I'm gonna do a amoeba on both feet.
Okay. Pablo.
I will go miss on this case, but only one. I don't like bilateral surgery in this type of patient. I'm afraid of because I'm afraid of they cannot control well the weight bearing. If you're afraid of bone quality and you're going bilateral, they are forced to full weight bear on your osteotomy. I don't really like it. One foot at a time for me.
1 minute, guys. 1 minute.
Okay. So I'm going to move.
Show the result, please.
Okay. Well, this is what was planned. Proximal metatarsal osteotomy and an aching osteotomy miss without fixation. First generation. The result at 6 weeks. Do you see early weight bearing on the first time with a post-op shoe? And the patient go well, 12 weeks, walking without pain, without hernias. So you have to do a bandage. There is option for you to still have first generation techniques, or it's just only with fixation, guys? That is my question.
Well,
I prefer the third generation because you can fix the osteotomies. I don't trust in the dressing. That's it.
Well, I guess we are on time. Selene, thanks for your invitation, and we are grateful to be here. We're really enjoying the whole meeting, and we're looking forward to participate again anytime if you want to have us again.
Oh, you guys are always welcome. You guys are Chilean brothers. So,
right.
All right.
Thanks.
Bye.
Thank you.
Bye. Stay safe.
We'll break for a few minutes.